Hey everyone! Today, we're diving into a topic that you are absolutely going to see on the wards, in clinic, pretty much everywhere. Drug-Induced Liver Injury, or DILI. Look, whether you're a med student, a resident, or just prepping for your boards, getting a handle on DILI isn't just a nice to know, it is a need to know. Just let that sink in for a second. This isn't some rare zebra diagnosis you read about once in a textbook. This is a frontline clinical reality. It is the #1 reason people go into acute liver failure. So knowing how to spot it, classify it, and manage it, that's a skill that can literally change a patient's entire outcome. All right, so here's our game plan. First, we'll talk about why DILI is called the Great Mimicker. Then we'll break it down into its two main types. After that, we're getting practical. We'll look at how to recognize injury patterns using a super simple calculation, and then we'll wrap up with the absolute core principles of management. Let's jump in. Okay, first things first. The biggest challenge with DILI, and the reason it's so tricky, is that it's a master of disguise. Seriously, it's known as the Great Mimicker of liver diseases for a very, very good reason.
I mean, think about it. You could have a patient whose labs are screaming viral hepatitis, or maybe their symptoms, like jaundice and itching, look exactly like a blocked bile duct. But nope, the real culprit could be a new antibiotic or an old blood pressure med. Because DILI can look like almost any other liver problem. It has to be on your differential diagnosis anytime you see abnormal liver tests. Period.
So, if it can look like anything, how do we even begin to get a grip on it? Well, the first step is to understand that we can divide all cases of DILI into two major categories. This is the first crucial branch point in our clinical framework.
You can think of DILI as coming in two main flavors. On one hand, you have intrinsic DILI. This is basically a predictable poison. If you take enough of it, it's going to hurt your liver. The absolute classic example is an acetaminophen overdose. On the other hand, you have idiosyncratic DILI, and this one is way, way trickier. It's totally unpredictable, it's not related to the dose, and it only happens in certain people who are just uniquely susceptible. It's more like a weird, unlucky reaction than a straightforward poisoning.
Okay, so how do we actually start to figure this out when we're seeing a patient? Well, we look for patterns. The patterns we see in the liver function tests are our first big clue about what kind of damage is happening.
The most common pattern you'll see is called hepatocellular. This is where the liver cells themselves, the hepatocytes, are getting hammered. This causes a huge spike in their ALT and AST levels. And look at the culprits here. These are drugs you see every single day. Acetaminophen, obviously, but also isoniazid for TB, statins, antivirals, allopurinol for gout. These are total workhorse medications.
Next up is the cholestatic pattern. Here, the problem isn't so much the liver cells themselves, but the flow of bile. So you'll see a big jump in alkaline phosphatase, or ALK-Phos, and bilirubin. And some of the drugs that cause this might surprise you. One of the most common antibiotics in the world, amoxicillin clavulanate, is a classic cause. So are things like oral contraceptives and certain steroids.
And believe it or not, it gets even more complicated. You can have a mixed pattern which is a bit of both, often from anti-seizure meds like phenytoin. Some drugs can even cause long-term scarring or fibrosis like methotrexate, and others can trick the body into launching an autoimmune attack on the liver. It really just hammers home how incredibly versatile this great mimicker truly is. Okay, so we have these patterns: hepatocellular, cholestatic, mixed, but sometimes just eyeballing the labs can feel a little subjective. So how can we be more objective? Well, there's a really neat and simple calculation we can use called the R-value.
The R-value is exactly what it sounds like. It's a ratio. You just plug in the patient's ALT and ALK-Phos, and it spits out a number that objectively tells you which pattern of injury you're most likely dealing with. It's a fantastic little tool to have in your back pocket.
And don't worry, the math is super easy. All you're really doing is comparing how high the hepatocellular marker, the ALT, is versus how high the cholestatic marker, the ALK-Phos, is. By looking at each one relative to its normal limit, you can see which type of injury is really driving the bus.
And interpreting the result is simple. Think of it like a scoreboard. A high R value, anything greater than 5, means the ALT is winning. It's a hepatocellular pattern. A low score, less than 2, means the ALK-Phos is dominant. It's cholestatic. And anything in that middle zone between 2 and 5, well, that's a mixed picture. It's a quick and objective way to classify the injury right at the bedside.
So, you've looked at the clinical picture, you've calculated the R value, and you have a strong suspicion for DILI. Great. Now what? What do you actually do? The management principles from here are actually pretty direct and absolutely critical.
This is rule number 1.
The single most important thing you can do, and the first thing you should always do, is stop the drug you think is causing the problem. Seriously, this isn't just a treatment, it's also a diagnostic move. If the liver enzymes start getting better after you stop the drug, that's a huge clue that you found your culprit.
Now, let's zoom in on the one DILI scenario that is a true sirens-blaring medical emergency: acetaminophen toxicity. As we've mentioned, it's the most common cause of intrinsic DILI and the #1 cause of acute liver failure, period. You have to know how to handle this one. Your action plan here is a clear 3-step process. Step 1, get a serum acetaminophen level stat. You need to know how much is on board. Step 2, take that level and the time since they took the pills and plot it on something called the Rumack-Matthew nomogram to see what their risk is. And finally, step 3, if that nomogram shows any significant risk, you give the antidote, N-acetylcysteine or NAC.
But, and this is a really big but, the nomogram isn't perfect. It doesn't work well if the patient shows up late, like more than 24 hours after they took the pills, or in situations of chronic overuse. So what's the bottom line here? It's simple. In these tricky cases, you still give the NAC. The evidence shows it helps even when the nomogram doesn't apply. When in doubt, give NAC. So that's the framework. But the story of DILI is far from over. I mean, this field is constantly changing. We're seeing new culprits all the time, like herbal supplements that people assume are safe, or powerful new cancer therapies. The core principles we've talked about today will always be your foundation. But this evolving landscape really challenges all of us to stay vigilant and ask, what's the next frontier in keeping our patients' livers safe? Thanks for tuning in.